Assalamu alaikum. Are you hearing me?
Yes, sir.
وعليكم السلام ورحمة الله.
Yeah. Good morning, good afternoon, and good evening, everyone. I will be share MDR TB outcomes in Afghanistan, a quantitative study of treatment practices. This research highlights key challenges and solutions to strengthen healthcare system improvements. And hopefully this to be interested for you. MDR TB occurs when tuberculosis bacteria become resistant to first-line drugs, making treatment more complicated. And this is a global health concern, especially in resource-limited settings like Afghanistan. Afghanistan has right now high multi-drug resistance TB burden due to treatment, non-compliance, and inconsistent healthcare services. And limiting to diagnostic tools, medications, supply shortages, and poorly funded TB programs hinder the effective patient care. And this was because of decades conflict that disrupted the healthcare infrastructures. This research examines treatment practices, systematic barriers, policies, recommendations through structured quantitative survey, healthcare professionals actively involved in TB management. The key challenges highlighted: raising MDR TB burden, affecting TB treatment success rates, low adherence to treatment due to financial, logistical, and socio-cultural barriers, and also inconsistent healthcare resources, especially in rural and conflict-affected regions. Further to that, stigma-related delays in seeking treatment, worsening multi-drug resistance TB spread. This research has key frameworks guiding us through the WHO TB guidelines, healthcare access methods, which examines availability and accessibility of healthcare infrastructures, and the treatment adherence theory, which explains why patients fail to complete MDR TB treatments. The study design was cross-sectional quantitative study using a structured online survey, and the participant and the respondent was provincial TB coordinators, laboratory supervisors, DOTS nurse, NGO TB focal point, and National TB Control Program members. The data collected through Google Form and distributed to 175 healthcare professionals across urban and rural healthcare settings. And the question, there were 23 structured questions which focused on resource availability, training adequacy, treatment adherence, and policy challenges areas. For the data analysis, we used Stata and Microsoft Excel. Further to that, we used inferential analysis to conduct and identify the key trends, relationship, and policy gaps. The key findings and the areas as mentioned: number one, resource accessibility challenges was unequal access to diagnostic tools. 70.3% of respondents facilities reports consistent availability of Gen expert machines, which is a strong point, and 5.1% lack of diagnostic tools and delaying the treatments. In regard to funding shortages, directly impact the treatment accessibility. 60% of the respondents mentioned adequately funding, but 11.4% classified funding, requiring urgent policy interventions. The second area was training and capacity building, limited healthcare workers training on MDR TB management, as 63.4% of respondents have not received formal training in the last year. Facilities with frequent training demonstrate a stronger adherence to guidelines, highlighting the need for regular capacity building initiatives. The third area was patient adherence barriers. Key reasons for treatment dropouts was financial burdens, which 61.1%, transportation barriers to the patients, 53.7%, which limited the access to healthcare services, and similarly, the social stigma was a challenge that patients avoid treatment due to fear of being labeled. The fourth area was public awareness and stigma issues. The stigma remains a serious restrictive to treatment. Over 53% of respondents identify stigma as a very significant barrier to patient adherence. And also, awareness campaigns have limited reach. Only 19.4% reports frequent awareness of campaign in their regions. Systematic policy and challenges, healthcare workforce shortages, 64% directly reduced patient outcomes. Similarly, lack of collaborations between government and NGOs, those are directly implementing the health services. Figure 1 illustrates varying levels of confidence among healthcare workers regarding adequacy of multi-drug resistance TB training programs, highlighting gaps in capacity building limitations. As here, you can see the percentages and the figures. Figure 2, comparing frequency of update on treatment guidelines, showcasing discrepancy and communication across healthcare roles. Figure 3, visualizing the availability, pie charts visualizing the ability of essential diagnostic tools, emphasizing shortages and critical regions. And figure 4, providing insights into adoptions of patient adherence strategies, and also for the MDR TB management for workforce shortages and availability. And the heat map, visualizing funding adequacy level across different regions, highlighting disparities and financial support for MDR TB management, which x-axis represents different regions and the y-axis shows funding adequacy level for us. This data highlights key perspectives on MDR TB management, showing a strong agreement on protocol monitoring and treatment integrations. It reinforced the need for consistent practices to improve interventions. These slides actually compare our findings with global studies. Research shows that conflict-related healthcare disruptions impact TB treatment success rate. The stigma negatively affect patients' retentions, and also lesson learned from Pakistan, managing adverse drugs events improve adherence. Building on the previous discussions, these findings highlights 3 critical areas for improving multi-drug resistance management. Healthcare worker trainings, funding needs urgent attention. Social and financial support system must be integrated into TB programs. Community engagement interventions are crucial for stigma reductions. This slide presents key recommendations to strengthen MDR TB management. First, strengthen healthcare training, frequent WHO guidelines workshops to ensure standard protocol adherence, specialized training for rural healthcare providers to improve accessibility. The second point, improve resource allocations, policy-driven funding reforms for equitable distributions of TB resources. Third, expand patient support program, financial assistance for patient facing transportations and treatment costs. And also peer counseling networks to improve retention rates and adherence. The fourth point is a scale awareness campaign, community-driven stigma reduction program to normalize MDR TB treatment. And further to that, use local influence healthcare advocates for educational outreach. These slides present future research directions. For the research gaps highlighted, needs for qualitative studies and deep interview with MDR TB patients, investigating long-term impact of new treatment regimes, better integrations, primary healthcare models, and finally expand and focus to underserved regions, understanding barriers in remote areas. And conclusions, to take away the key point, equitable healthcare accesses and sustainable interventions are essential, and improve funding, training, and patient-centered support programs can enhance multi-drug resistance TB management in Afghanistan. And the final statement is that strengthening collaborations between governance agencies, healthcare professionals, and NGOs is crucial to improving MDR TB outcomes. I would like to acknowledge the National Tuberculosis Team of Afghanistan for their support in data collections. And further to that, I also want to thank my university, Universitas Dian Nuswanturu faculty for academic guidance. And the key references for this study, WHO MDR TB guidelines, studies from Pakistan, Somalia on TB management, and regional researches on MDR TB patient and retention and stigma challenges. Thank you very much. I will happy if there is any questions from the member of this conference. Thank you very much once again.
Thank you, Mr. Mohammad, for your insightful presentation. We now open the floor for any questions from our delegates. Please raise your hands.